Faisal Al-Suwaidan, and we would like to welcome Dr. Salih Al-Khanain. Dr. Al-Khanain is a neuroanesthetist and neurointensivist at Prince Sultan Medical City, and he is going to talk today about prognostication of severe TBI patient, ethics, and family approach. Dr. Al-Khanain had expert in the field of ethics, a neurointensivist in general, and in Islamic ethics in particular, and we're happy to have him tonight with us. Please start, Dr. Al-Khanain, your presentation. So we're going to have 40 minutes or so for the presentation, then last 20 minutes for questions. So please go ahead, Dr. Salih.
Whoa, Dr. Salih.
Thank you, Dr. Haifa, and I'm really excited to be with you. Thank you so much for you personally and for the Neurocritical Care Chapter for giving me this chance to elaborate more about this important topic, which a little bit has some controversy and a lot of talk, but we will try to cover as much as we can. So the Hippocratic dictum said that there is no head injury is so serious that it should be despaired of, nor so trivial it can be ignored. What does that mean? That actually there is uncertainty that exists around likely that the outcome for patient after sustaining traumatic brain injury is most accurate at that time. So it is an old thing that the traumatic brain injury outcome and prediction of the outcome is something actually unclear since long time. So till now, still, though that there is many advances in the modern medicine, and still actually clinicians estimates of prognosis is not that unduly optimistic and really still cynical and confusing, and there is the unnecessary. Can we just close all microphones, please, for those joining? So the prognosis and prognostication on patients who suffer from severe traumatic brain injury, perhaps only mirrored in its complexity of the pathology itself, and the nature of the injury itself, and the diversity of the patient from one patient to another, and the type of the injury actually the patient sustained. That's why there is actually different pathophysiology consequences according to the patient mortality, morbidities, and type of injuries, duration of injuries, quality of pre-hospital care, and so on. So, I went through actually many articles through the last 25 years, and early actually that there is new chances actually that in the last 25 years they started to have what is called the indicators for the prognosis in a severe traumatic brain injury. So since that time, actually, there is some clear indicators for one reason or other. Let us talk about the incidence of traumatic brain injury in the, for example, in the Western United States, that it is different from country to country. Type actually of the injury is different. For example, we can see here that it can reach up to 250 per 100,000 population in the United States, while in Europe actually it is more. Actually, the incidence is more, and even the type of the injury itself.
Bro, Josepha, shut the fuck up! Josepha, man, your microphone. Always.
So we still actually the number here is underestimated, because all the studies talking about the number of survived patients reaching the hospitals, while they don't take into account those who had mortality during the transportation, or those actually who did never attend at all, who have even mild or moderate actually traumatic brain injury. So risk factors actually associated with traumatic brain injury, which may be considered actually in the prognosis as the age, for example. I will not actually consider that patient with traumatic brain injury, young chap at 15 or 20 or 25 years, like those who are in 70 or 75. And for one reason or another, actually, regarding the ratio itself for 6, which can affect also that sometimes the outcome of the ratio in some studies, that it is 2 to 4 to 1 for the male and female. And sometimes those with substance abuse or those with alcoholism, they actually offer different outcomes when the incident happened. So it's one of the parameters that to be considered. So the majority of the patients in our society in Saudi Arabia are young, presume that previous good quality of life and the considerable actually numbers of them are young. If we go with some pilot studies, there is no accurate actually studies from different health facilities, but most of them, they are young. So is that what we call years of life lost? So the severe traumatic brain injury has many potential consequences even after the injury. Those talking about behavioral, psychological, psychiatric, and consequences, and those actually may increase the national burden of the disease, the drive for high long-term health care, and the cost actually for any nation, which may cost a lot for that things. And that's why actually we will talk a little bit about the ethics of communication with the relatives once we have such type of patients in our ICU unit. So almost 50% of those patients with traumatic brain injury are result actually in Saudi Arabia. Number one is the motor vehicle accident, with less actually incident of bicycles, followed actually in here again by pilot studies that by the falling actually during construction, and even the pedestrians as number 3. So violence actually is around less than 20% actually in our society. So patient who sustain the severe traumatic brain injury, we are talking about the severe traumatic brain injury who reach actually the ICU. They need actually to be fully resuscitated before actually we can put a plan of the or estimate of the prognosis or attempt. So the prognostication actually, what is the meaning of that? So the prognostication, it is really continuous effort. It's ever evolving, and if a patient responds day by day, and sometimes we can give prognostication 2 or 3 times per day as a result actually of the medical or surgical resuscitation and the initial acute management. Their prognosis may continue actually to change. From time to time, from attempt to attempt, actually, secondary insult, which has already vulnerable the brain person. So it
Dr. Saleh, please unmute yourself.
Okay. Okay, the sound is clear right now?
Yes.
Okay,
Thank
great.
you.
So it is important that before considering actually putting the a report of prognosis or primary report of prognosis, that the patient should receive full medical and surgical resuscitation, which can actually make a lot of difference. For example, the craniotomy, if there is subdural or epidural hematoma, medical resuscitation for electrolytes, for example. And there is actually, although actually that it is very relevant question from critical point of view regarding the patient prognosis, in most circumstances, and what we are saying that there is actually guard and pursue for the crystal ball, not what we call the magic crystal ball, to answer what will be the next, what will be the result tomorrow or after tomorrow for patient traumatic brain injury, and remains for most of the intensivists and neurointensivists from time to time that it is something elusive, that there is no clear clue, no clear answer. So we can see here actually some studies, though even actually to the last few years, that many studies done investigating different prognostic and scheme combining actually clinical science. They actually consider the other parameters like ventilator parameters, hemodynamic parameters, and intracranial dynamics and other things for the prediction of the prognosis apart from the neurological parameters. And recovery from traumatic brain injury, mainly severe traumatic brain injury, necessitate actually long time. Sometimes it may take months or more than a year, actually it depends on the centers, it depends on the circumstances. Actually, the patient presented to, it depends on type of recovery, and again, it depends on the pre-hospital resuscitation, initial resuscitation, and transportation. So this really requires ongoing commitment to the treatment and rehabilitation system that often actually struggling to prioritize actually the and manage the limited resources. So let us just ask ourselves, what is health? What is the health? According to the WHO, the latest definition, that the health is defined by state of complete physical, complete mental, and social well-being, and not merely the absence of the disease or infirmity. So, and does that match? And many TBI patient survivors are left with permanent physical, emotional, cognitive disabilities, where they are falling actually in a short or sometimes long term, actually all the three parameters of the WHO parameters regarding the definition of the health. And this actually will come to us. What is actually the psychological consequences? We know that many of them, even if they have almost actually recovery after rehabilitation, that they have actually sometimes behavioral disabilities, sometimes they have physical disabilities, they have actually, for the caregivers, they are suffering from sleeping disturbances, the problems with judgment, problems with aggression, personality changes, depression and anxiety, and reduce actually social skills. And most common of these actually impairments is the short-term memory, that in some studies it exceeds 40% that they have actually problems with short memory and impulsive behavior. And we'll come to that when we will join all of these things with the ethics regarding dealing with such type of patients. So we can say that the temporal or the dominant temporal lobe injuries can result really in communication difficulties and many disorders, about the speech, about the language, and even skills of language can be lost. So these deficits actually disabling affect the patient's ability to engage with the rehabilitation, with the society, and cope with the activities like what they have used actually to do before with their families and their communities. So in social background, maybe I presented a presentation maybe 4 or 5 years ago regarding the social impact of those patients, that they have really poor social skills that is really a result in really dangerous situation for the patients and for the incidence of criminal records, and link between the traumatic brain injury and criminal behavior is well described in many literature by many psychiatrists actually since long time. So, and we have this study it is a Finnish study with the adolescent with the TBI found to have committed crimes in a significant number. There's more adolescents without history of TBI, for example, and those who are recorded with crimes, when they dig about their history, that they found that 53 of them, 0.8, found to have traumatic brain injury in their life, compared to 14.7 of those who have nothing. So prevalence of violation and crimes actually is high if we compare those with traumatic brain injury, post-traumatic brain injury to the normal. So rehabilitation of patient is very important. If we are talking about rehabilitation, I'm not talking about the physical disabilities, paraplegia, hemiplegia, and so on, but we are talking about the psychological rehabilitation, language rehabilitation, and so on, to keep with the family and actually early prevention. And that's why in the specialized neurocritical care units, usually they started rehabilitation as soon as possible whenever the patient is ready in the ICU itself, before transferring them to a rehabilitation center. We know that actually those patients with traumatic brain injuries, they have a lot of systemic consequences like gastrointestinal, musculoskeletal complications, infections, epilepsy, and so on. So they are really suffer. So it is an issue for the caregiver, for rehabilitation centers, for the society. It's really costly. It's not an easy as some will take it actually easy for those things. It is one of the most costly rehabilitation disease ever in all pathologies, if we are comparing this pathology to other things. So the post-concussion, for example, syndrome is another complex disorder which may occur in patients after sustaining even mild traumatic brain injury, in which concussion symptoms such as, for example, headache, dizziness, sleeping difficulties, memory problems, and sometimes it will lead to withdrawal from the work itself. So what about the severe traumatic brain injury? The picture will be totally different, and will be totally actually more dangerous and more catastrophic and more costly in the caregivers, in the families, of the society, on the nation itself, and for the governments. So management strategies for traumatic brain injury should follow a three-tiered approach to yield the best result, as I mentioned before. Should start actually from the critical care itself. That will include prevention and evidence-based acute medical management and long-term rehabilitation as soon as possible, as soon as the patient is ready. So the prevention strategy typically fall in the realm of the healthcare administrators and the strategists and healthcare leaders and policy makers, that they should adapt actually a roadmap for the safety of rehabilitation for those type of patients that will fall in prevention of the consequences of other catastrophic problems that will consume actually the resources of the health institutions. So the acute medical and surgical management is really, as soon as possible, is aimed to minimize this secondary brain injury that will give the patient the best chance of good outcome. That's why you will find in a lot of literatures that the outcomes totally different from center to center, from area to area, and factors is really different. It depends on actually on the presence of a specialized intensivist, on the specialized units, and actually competent other caregivers more than the critical care itself. So here we have actually this study in 2 years back about the outcomes of severe traumatic brain injury at the time of the discharge from a tertiary academic hospital in one of the good centers, which gave a good result. On the other hand, you'll find totally different numbers if we compared actually studies, for example, in a center, even in the United States, to another center which has actually less outcome. That the main problem actually is the quality of the critical care itself and the quality of the health center itself. So the availability and accessibility of adequate post-hospitalization, rehabilitation, and paramount importance to ensure the better outcome. Locally, there is actually a chance of what I can say impacts to some rehabilitation. Let us admit actually that the critical care rehabilitation early in many centers locally, nationally, this still actually needs a lot of improvement, not only in public centers, but also in private sectors, that we have a window to improve ourselves. So the consequences of the traumatic brain injury patients is very few receive really adequate rehabilitation service. Let us admit about that. And that's why we have a lot of actual disabilities and ignored disabilities. So traumatic brain injury may include initial period of amnesia, usually involves the slow recovery period. The candidates for rehabilitation may exposed to behave appropriate in around 6 to 12 weeks period in moderate actually traumatic brain injury. This affects actually their ability to gain the maximum service from necessary rehabilitation centers. And that's why that the proper rehabilitation, if not preceded by proper critical care resuscitation, it will make a lot of difference. So the patient are, instead of discharged, unprepared to the families who are typically become their main support, especially here in our society in Saudi Arabia. So severe traumatic brain injury will typically occur by the multidisciplinary team. It's not only the critical care, but actually the psychiatrist, the physiotherapist, the occupational therapist, the speech and language therapist, neuropsychologist, rehabilitation nurse, and social workers. So all of those actually the team and the multidisciplinary team, their goals actually is to stabilize the medical and rehabilitation issues regarding the better outcome for the traumatic brain injury for cost-effective complications. So prediction of the outcome involves actually the probability of the statements and depth of the rational relationship between outcomes and parameters actually condensed in early data. So the advances in prognosis reflect the established method of categorizing the outcome according to the severity. So it's always good to have actually local scores, local categories for each ICU unit. So these actually parameters, it became really accepted worldwide in multinational, multi-center studies according to them, and depends on the centers actually accepting the guidelines and scores actually there. So the nature of the injury and the early clinical course with distinctive and consistent relationship and the outcome. So in severe traumatic brain injury, really it remains a devastating condition. And even at the best medical center that has major physical, neurocognitive, psychological, as I have said before, all of these complications can end up to long-term rehabilitation follow-up and actually a lot of cost on each nation. So we remember actually the physicist Niels Bohr, who has, at least in the context of deciding whether or not to treat the individual patient, it's important to continue acknowledge that this physicist, the great physicist, who got actually Nobel Prize at stage of his life, the prediction is very difficult, especially about the future. And he's a good example actually of those patients who gave actually the caregiver his early decision. So do all radiologists do their reports with scores? Let us ask ourselves, according to your center there, have you ever actually read with the radiological reports, for example, CT scan, a radiologist who gave also with their reports actually score? We have, for example, the old Marshall and Rotterdam scores, and we have some recent actually scores for Helsinki and Stockholm. Stockholm actually is a little bit complicated for me actually, and Helsinki is good actually indicator. So, and we have actually some recent study that can, for example, from radiology, it can predict the outcome. This is actually a PhD work by Tooth. He's Hungarian, and he's measuring the lateral ventricle volume asymmetry that can predict the midline shift with severe traumatic brain injury. So it is volumetric measures actually that can predict actually things, and it is really a good work. So what about the ethics for TBI? The ethical issues actually is raised from new technologies that can determine the diagnosis and prognosis of those patients. In what way? How the physician should manage the inevitable and uncertainty that arise from this determination, and how the physician can optimize the surrogate and those around the patient for the consent refusal of treatment, into process of shared decision making when it is really from in advanced care planning, and how a new functional neuroimaging, for example, and new functional technologies that impact the patient rehabilitation, impact the patient treatment, and impact the patient palliation and prognosis. So one of the ethical things actually is the correct diagnosis. So why is clinical ethicists actually respect the maxim which say that good ethics start with good facts? If there is good facts, actually it is correlated always with good ethics. So this maxim means that one cannot begin an ethical analysis of a clinical problem until he do actually medical facts of the problem. It's always should be the fairest, clarified and agreed upon. So in the setting of the patient with severe brain damage, the first important medical fact it's that the physician makes the correct diagnosis, placing the patient in the correct diagnostic syndrome, And the most important syndrome of the physician to consider in those patients with severe traumatic brain injury are the brain death, coma, vegetative state, minimally conscious state, and the locked-in syndrome. So it is VS, MCS, and LIS. So a correct determination of whether the patient possesses and exhibit actually measurable awareness of the self-environment is really intrinsic and really diagnostic task, which differ from an intensivist to another, according to their experience. So the ethical problems arising from those misdiagnoses are obvious and probably actually dwarf to all other ethical problems arising in those in their care. So severe brain injury damage with alteration of the level of consciousness usually should be examined using the standardized technique and to maximize the patient opportunity for showing responsiveness while carefully observing and scoring responsiveness to stimulate and standardize the scale and develop the purpose. And here I want to emphasize on one thing, that one of the most important stuff inside the critical care is the nurse. Well-trained nurses that can actually observe and notice the patient and record actually neurological incidents second by second. So nurses or family members sometimes who have observed patient responses, for example, that they interpret as showing retained awareness, for example, for what they think that he returned actually awareness for a short period, should be asked to demonstrate them and take it actually seriously of their notice. Finding, for example, the other facilities like actually tools for like EEG, evoked potential, CT scan, MRI, actually should be all of that as neuromonitors should be incorporated all together to formulate actually an extent and cause of the brain dysfunction or aid in the diagnosis and prognosis. So a clinical examination should be repeated every now and then, and which he should not be actually ignored that he is always in vegetative state, but the patient should be actually regardless. It depends on from patient to patient. Sometimes we are doing examination on daily basis, more than once daily, sometimes every other day, and so on. It depends from one patient to another to mitigate actually and follow up the prognosis and the progress of the patient. So it is well known that the patients with traumatic brain injury sometimes can have transition from coma to, for example, VS or to MCS, or even it may take this thing months or more than that. So once the emerging functional neuroimaging studies in the last 20 years fully tested and validated, we have many studies, for example, in the functional MRI, for example, that it helped us actually to alter the diagnostic criteria and find actually more scaling criteria for this patient. So patient areas of brain activation shown by the functional MRI or evoked potential and other things task, it gave actually suggested that they probably possessed awareness that the time at that time that shows diagnosed in the consequences of the traumatic brain injury, and for example, even sometimes if the patient vegetative state. So functional neuroimaging studies have produced an analogs to impact our understanding and diagnosis of the MCS. So in the last 15 years, actually, a lot of studies, we became more knowledgeable, actually, and even the families, they became more knowledgeable and about the when they are reading some studies, even in the media, which broadcast all of these things. So sometimes families, they are requesting, for example, for those patients after a period of time, functional MRI testing to their lovers, and for example, already they are vegetative state or MCS, that they should not actually, as a compassionate for them to see what will be the next for tomorrow. So the maxim as I said, for the correct prognosis, good ethics start with good facts. So although the patient's determining the prognosis actually for survival, for recovery, for awareness, or good actually neurological function is a critical question that will be asked on a daily basis by families to the intensivist, and we should be always clear with them and give them frank answer. We should not actually so transparent about our questions and about our answers, and to give them even the statistics and the evidence-based actually medicine records in that thing. So the answer to the prognosis, their question, is really essential, and define actually type of patient's medical care, because of the patient and the family members would request actually aggressive treatment in if the prognosis, for example, for recovery was favorable, but not if it was poor, for example. In our society, let us actually talk about our society here in Saudi Arabia. So most of the people answer that they would not wish to remain living in a vegetative state if there was no reasonable hope for recovery. But many people believe in our society that there is irreversibility of vegetative state, which is a state of worsen than they consider that it is a state of worse than death. So making an accurate prognosis really something indispensable and prerequisite to clinical decision making. And sometimes it's very difficult to answer them, like making, for example, accurate diagnosis for the ethical problem resulting from making an accurate prognosis and obvious profound things. That's why medical malpractice departments usually facing some suing some clinicians because of the communication problem. So physicians should make their evidence-based prognosis, and I'll repeat here, the intensivist should make their evidence-based prognosis for the brain injured patient, and they should be so transparent with the patient. They should tell them, for example, they will say that conditions like your patient, your relative, your father or lover is out of 100, for example, 7 survive. But we cannot say anything more than that. Exception can always happen. So an important limitation to the pronouncing an evidence-based prognosis on a brain injured patient has been called, they call it the fallacy of the self-fulfilling prophecy. So most outcomes actually studies are is really experiential and depend on the experience of the intensivist rather than anything else. So it is really a fallacy. So the impact of the fallacy of the self-fulfilling prophecy on the asserting the prognosis of the patient with severe injury, it really has been studied a lot for the last 30 years in 2 common serious neurological disorder. And Dr. Haifa, mashallah, she's expert actually in coma after cardiac arrest actually and intracerebral hemorrhage. So the statistical nature of the prognosis of the creation, inevitable and irreducible degree of uncertainty that further studies and a lot of studies can be done to listen, but never eliminate. It will never eliminate the dilemma regarding the prognosis. More studies we will be more actually aware about things. Hopefully that in the future, inshallah, that something good will happen. So it's likely that with the validation by the further studies of functional MRI, when it was actually new 15 years ago, and like now actually, which became part of the neuroimaging in many tertiary centers, including here in Saudi Arabia, to reduce actually the diagnostic and prognostic uncertainty for a limited actually number of patients. But inshallah, in the future, the essential of the ethical problems will remain for one reason or another. So the surrogate regarding the the consent and refusal, which is, again, it is a headache for us here, at least in my society. So severely brain injuries, injured patients are nearly always lack the capacity, of course, for the treatment and decision. And the informed consent doctrine, العقيدة الموافقة is require three things, three conditions that make the patient consent valid. The patient has the capacity to make and communicate for the care decision, and the patient is given the understanding and the information, for example, if he's interested, for example, necessary to make the informed and rational decision, or his relative or legitimate relative. And the patient is not corrected by people or agencies, for example, for those who has nothing. And we have actually the medical consent guidelines or booklet, الدليل السعودي للإذن الطبي. You may refer to this actually guidelines. It is online as PDF and on the Ministry of Health website. So again, one of the ethical things is the shared decision-making. From the beginning, the contemporary expression of the doctrine of the informed consent from the beginning is to share the decision. Let them actually share the family with you from the beginning regarding those with severe traumatic brain injury. It is something lawful for the surrogate to involve them actually in the decision, make up the decision altogether. So as dad, كثنائي. The physician actually contribute actually medical facts and opinions regarding actually diagnosis, prognosis, the treatment option, and every now and then actually to live on that. Proper communication will end up actually with proper decision making that you will involve them with you. So advanced care planning, regarding the importance of mechanism to assure that the relatives or the surrogate respect and follow up the treatment preferences of the patient and become actually incapacitated and cannot, for example, if they make them actually isolated and independently actually consent or refuse actually for the treatment. In case of our patient, it has actually clear guidelines in Saudi Arabia, to be honest. And in the case of the patient with severe actually traumatic brain injury, often actually young here in our society and previously healthy and advances actually in care planning. So it is good actually to involve the relatives and surrogate from the beginning about each step from till the end of life. So an important element, because at the end actually the patient will go for them, even if we will discharge them from the ICU to the ward and later on to the rehabilitation. So an important element of the advanced care planning is the execution of advanced directives. I will say that for a million times, advanced directives for medical care. So the rehabilitation, whenever actually it is possible for the patient, as I said, that inside the ICU, especially for those specialized ICU for neurocritical care, and those patients severe traumatic brain injury will be treated in neurocritical care, then to the neurorehabilitation units that specialize in actually brain injury, because of the evidence that early intensive neurorehabilitation always improve the outcomes. And I believe so, that even the specialized neuro-intensive care nurses actually will make a lot of difference for those things. So in conclusion, there is actually a pressing need to formulate a Saudi national ethical prognostication guidelines based on the international evidence-based practice, with the consideration to the cultural privacy and the legitimate background. And fortunately, alhamdulillah, we are working, actually, I'm a member among a group of people, and my colleagues actually here sharing as moderators for this session. Actually, they are also members in a national effort to end up, inshallah ta'ala, within in the short future, inshallah ta'ala, for these things. Other things is the additional studies of the functional neuroimaging and other emerging diagnostic technologies on the severity of the brain injury patients can help in prognostication. That's all from my side, and thank you.
Thank you very much, Dr. Saleh, for this nice presentation. And Assalamu alaikum, everybody. Very enlightening and it's shedding light over many untouched corners in the practice of ICU and neuro ICU. We'll be happy to take questions. Please raise your hand, and then we'll call your name to open the mic and take your question. If anybody has a question, please use hand raising function, and then we'll take your question. So, Ms. Maha, go ahead. Ms. Maha Liami.
السلام عليكم مانع اليامي.
Mana, Mother. Sorry, Mr. Mana.
No problem. Doctor, I want to ask, what is the time? Is there any specific time to give prognostication about the patient state from the after the medical and surgical management?
This actually, to answer this question is very difficult because it is different from patient to patient, different depend on the type of the traumatic brain injury, the extent, the severity, and the comorbidities with the patient. And that's why we call it prognostication. It's not a prognosis. It is a prognostication that even at the same day, I can give a prognosis in the morning and the other actually change actually my prognosis in the afternoon. So it is a dynamic actually prognostication things. It is a dynamic process that is really different even for the same patient. So there is no single answer for that. It depends on the type of the injury, extent of the injury, and even the comorbidities of the patient.
Thank you, Dr. Saleh. That is very correct, actually. We have to, put our patient in the correct category before we start the prognostication process. I hope this answers your question, Mr. Mana. We'll take another question. If anybody has a question, please raise your hand. We'll give you the chance to speak up and ask a question. Anybody else who would like to have a question to Dr. Saleh Al-Khneen? Okay, Shahri, yeah. Mr. Shahri, or go ahead. Ahlan wa salaikum salam. Yeah, go ahead, please.
Thank you very much, Dr. Saleh, for your nice overview about such difficult, consideration related to the traumatic brain injury. I am a pediatric intensivist, and we share the same, ethical issues, and sometimes we face more traumatic psychological trauma. Family, parent, psychological trauma about their child, which make them very difficult to accept, or at least let us say the the grave reaction of the family keep evolving along the length of hospital stay. Let me, I have some this if I'm in the right direction, or I have some overestimation of some of these ideas. Number one, we are as intensivists sure about the prognostication factors related to the resuscitation of traumatic brain injury when the child evolves fast in irreversible brain damage, like evolving brain death. That is very quite clear for us during the acute phase. But believe me, if you get the patient out of the traumatic brain injury protocol, and you're getting him to the rehabilitation phase, starting by trial of extubation, you have sometimes struggle, and you give the patient chance, and then chance. The difficult part for me, which I face it, is not the family. It's really about the challenges among the multidisciplinary. Our colleagues, neurosurgeon, radiologist, and neurologist. It's very difficult when you pull them around to give a clear facts for the family, looking to the whole clinical progress plus the ancillary and diagnostic workup or the intervention that has been made during the TBI protocol or around that time. So if everybody will give you some descriptive features, but when it comes to what should we talk to the family, it's sometimes you find some reluctance from our colleagues to give really sharp diagnostic criteria, especially in pediatrics. I don't know if that is true for adult traumatic brain injury. So failure of the team to come up with a clear message based on the diagnostic workup or the intervention that has been made is sometimes the big challenge to progress in the next step, which is how to convey the message to the family.
Thank you, Dr.
That's
Sherry.
my biggest issue.
It's clear. Your question is clear, Dr. Saleh, please.
Yes, maybe Dr. Faisal, you remember, just to answer Dr. Sherry for this thing, that we mentioned something regarding the health leadership, that it is multidisciplinary efforts by that needs actually strict strategy for health leadership. If there is an issue with this circle, for example, that the rehabilitation is bad, the radiology actually is not cooperative, and other, for example, we don't have a specialized, for example, intensivists actually who are expert in that, is just actually, for example, part-time or whatever, it's not working in the ICU for it's a lot of things that the specialized centers and good leadership, good strategy for each centers will end up by good location. If you will just go with some studies there, that in some tertiary specialized neuro centers that incorporate all facilities, all effort as early as possible, this actually will affect the result. You are talking about, for example, and that challenges. I will not say that it is system failure, but it is something challenges and obstacles in the system to go as perfect as we are wishing to. So and that's why from here that constitution in the beginning, well, التشريعات in the beginning, guidelines, and even to have proper leadership for the whole system, للمنظومة as a whole, actually make a lot of difference. And if you dig about the question you raised then, if you dig about the circle itself, you'll find that there is a defect in one area. Not necessarily the intensive care unit, but maybe other facilities that will make your life difficult actually to give the proper medical care to the patient as early as possible.
I cannot agree more with Dr. Saleh. We have a comment from our co-chair, co-moderator, Dr. Haifa. Go ahead.
Thank you very much, Dr. Saleh, for this great summary. Especially we have a lot of general intensivists, and most of our ICUs doesn't have 24/7 coverage, or doesn't have at all neurocritical care coverage. I think the message is clear here. It's just a careful, clear prognostication is very important. We should give time, especially for young patients when they don't have devastating injury. And especially the evidence is really not clear, because sometimes we see that patient with diffuse axonal injury, mainly involving brainstem, has poor prognosis, and lately there are evidence or emerging evidence that those patients with has diffuse involvement of the brainstem with diffuse axonal injury, they recover awareness. So we have to be cautious, careful assessment, give time. There is recent study released maybe 2 months ago in JAMA, analysis of the TRACK TBI trial. They assess a patient after 2 weeks, 3 months, 6 months, and 12 months. And they found that the trial include more than 450 patients. They found that patient who were vegetative at 2 weeks after a severe traumatic brain injury. They recover awareness, and they at 12 months, and they can live independent for at least 8 hours per day in terms of eating and washing and doing daily activity. So it's really not like one size fits all. We should include, as Dr. Rashiri, also multidisciplinary, give time, and also inform the family. Family should understand there is some uncertainty, and some reported cases they recover after 6 months or 12 months. So it's a patient himself, type of injury, time, comorbidities, other associated extracranial injuries will affect our decision.
Thank you.
Thank you very much, Dr.
Thank you very much, Dr. Haifa, for your comments, valuable comments. Please, again, I have to remind you, if you have a question, raise your hand. We will give you the chance to present yourself and also to answer a question through our delegate speaker, Dr. Salih Khaneen. I can see. I think we're almost finishing. We have one, probably 2 minutes. If no further question coming to us through the hand raising function, Dr. Haifa, if you would like to conclude.
Sure. So it seems that no more questions. Thank you very much, Dr. Khaneen, for a great presentation. It's a pleasure to be with us tonight. Thank you very much, Dr. Faisal Swaidan, for a great contribution and being co-chair for this webinar. Thank you very much for you joining us at this time. Hope was beneficial, and we'll meet you, inshallah, next webinar. Thank you very much.
Thank you, Dr. Haifa and Dr. Fawaz, for giving me actually such a chance actually to contribute, and which actually it was digestible information. Have a good night.
Thank you very much,
Likewise,
Dr.
Jazakumullah
Salih.
khair. Thank you very much, and see you soon. Goodbye.
Goodbye. Thank you very much, everybody.